in detail surgical anatomy, liver anatomy study should be done by triphasic CT scan. And post-operative hemorrhage and bile leak should be avoided by using either ligature and suture. Now, preoperative bleeding, inflow and outflow control. Control of inflow and outflow system. Always remember, hepatic vascular. Whenever you do it, most of the time, we don't take outflow occlusion. Very few times we do it when you have to finish surgery fast. Usually we do inflow inclusion. That is non-selective. That is Pringle maneuver every 10 to 15 minutes, and we give 5 minutes break. That is called preconditioning. Selective when hemihepatic or segmental occlusion. I got one video I'll show you. It is glycine empirical approach. And in and outflow occlusion is called total hepatic vascular occlusion or selective vascular occlusion. When patient is bleeding, patient is destabilized, you're halfway through the surgery. That time, entire liver you do vascular exclusion and you do resection fast. Whenever you do total hepatic vascular exclusion, you make sure that your hepatectomy should be done within 10 to 15 minutes because total hepatic vascular exclusion liver may not tolerate more than 50 minutes. Pringle maneuver. This is commonly used, inflow control with in all the liver surgeries. So Pringle maneuver is technique with stop blood inflow to the liver, purpose to reduce preoperative blood loss, and also precondition. Always remember that it is using Pringle maneuver is also good for future liver because whenever ischemia happens, there is preconditioning for cells helps in regeneration. Intermittent Pringle maneuver is ischemia reperfusion of liver. Some people use 15 minutes and 5 minutes break. Some people use 10 minutes and 5 minutes break. I use in between. I use like 12 minutes of Pringle maneuver and 5 minutes of break for. Make sure that you shouldn't use more than 10 Pringle maneuvers. So usually within 10 Pringle maneuvers, your surgery should be done. Most of the time, it takes 6 to 7 Pringle maneuvers on an average. There are reports that continuous Pringle maneuver, continuous ischemia without reperfusion from 60 to 90 minutes. But I don't recommend that. It can be done when tumor is very big, liver is entirely normal. In that case, it may tolerate the ischemia up to 60 minutes. But still, I won't recommend first were usually the standards. You can take screenshot of it. It is the study which shows comparison of vascular clamping technique, hemodynamic effects, and limits of clamping duration. If there are students, please take the photograph of it and please study it. It's very important. Okay. I'll just keep it for few seconds. You have to take photograph of it and then I'll run through the slides. Okay, I'm moving on to the next slide. This table is a comparative study using different vascular clamping technique, its hemodynamic effects, and clamping duration. Okay. Now, selective inflow occlusion. Clamp the right or left hepatic hilar depends on the tumor on left or right side of hemiliver to be resected. For example, just imagine that we got a tumor on the right side. You decided to write hepatectomy. That time, what I do is that I dissect the right pedicle, right portal vein, right hepatic artery separately, and first I use I use Pringle maneuver to start hepatic resection. After 25% resection is done, that time I put complete clamping of the right portal vein and right hepatic artery. So when you ligate the right pedicle, you have to make sure that your surgery that surgery becomes irreversible, right? You cannot, this surgical step is irreversible. So when you ligate your right and left, when I'm talking about right hepatectomy, suppose we're doing right hepatectomy, when you ligate the right sided pedicle, once you ligate it, it is irreversible. So sometimes, I always recommend that you shouldn't do any irreversible step at the beginning of surgery. So that is the reason I start with Pringle maneuver. I do first 25-30% of transection. And then when you're very much sure, okay, surgery proceeding rightly, there are no other way there, you have to stop surgery, everything going smoothly, no event. That is the time I make this irreversible step. So I ligate the right hepatic artery, right portal vein. Now there is no right inflow at all. And now you will ask, like, then why we need Pringle maneuver? Because even though you're doing right hepatectomy, there will be, you'll be keeping middle hepatic vein in the remnant liver. There will be some blood coming from the left side. So when you do complete right inflow occlusion, ligation plus Pringle maneuver, so virtually there is no blood flowing inside the liver, no from the right side, no from the left side. Whatever blood remains in the vein, that is coming from the right hepatic vein or middle hepatic vein or left hepatic vein. Whenever you cut, so there is the venous oozing coming, retrogradely. So in such cases, sometimes, if catastrophe happens, unfortunately, if you damage the middle hepatic vein, actually most of the time the bleeding is not the cause of having problems on the table. It is the air embolism, because these are high venous flow system. Once you cut the major system, they immediately suck the air inside. So whenever you have this situation, that is the time you do complete vascular exclusion, remove the remaining part of the liver. Fortunately, I never reached to this stage. I never came across this catastrophe, but I have seen people coming across this catastrophe and they have to apply all these things. So always, proceed meticulously, step by step, identify all the structures. The fast liver surgeon is the one who proceeds slowly. Remember, the fast liver surgeon is the one who proceeds slowly without repeating the steps. So make sure that your clip doesn't fall. Make sure that you go up further and the previous clip falls down and starts bleeding. These things shouldn't happen. So ligate, identify ligate, and whenever possible, suture. Go in traditional way. My thing is that 1 millimeter vessel you burn, 2 millimeter vessel, and as a surgeon, you get acquainted with that, which is 1 millimeter vessel, which is 2 millimeter. You don't have one year caliper to measure with this 2 millimeter or 3 millimeter. On everybody knows they got sense of the diameter recognition on the table. So the roughly 1 millimeter you buzz, 2 millimeter you put clip, 3 millimeter or more you ligate, clip or ligate and suture. If it is a pedicle, then you must ligate and transfix it. So virtually the slippage of ligation and then lateral bleeding or bile leak is virtually avoided. Patient. Proceed to the next. So now, this is Gleason pedicle approach. So it's a brief video. I'm going to run through it. And I will, as the video proceeds, I'll just make it fast forward. It's 3 minutes video. Now you see this is the hilum. Sometime you can put this soft clamp. If you see here, sometime Pringle maneuver you cannot obstruct the complete blood. So you clamp it. Make sure that the important delicate structures such as arch and bile duct don't get damaged. That is the reason the clamp which is applied, it just got soft rubber clamp. Now here I am uh, going in the hilum on the right side. This is now complete right pericle. Okay, always remember that the liver anatomy is the pericle divides in the right and left side, where artery and bile duct and portal vein, the division remain in the same glycinian pericle. There are two ways: either you do it separately, but sometimes you can do it as a bulk. Now this is right anterior glycinium pericle, so it contains everything. It contains right anterior duct, it contains right hepatic artery, it contains right portal vein. This glycine is right anterior approach, and the one here you see is that. So and now I'll pause it here. I'll pause it here. So if you can see my cursor moving here, now this entire part is right pericle. Usually what I do it separately, uh, because it entails a little bit blind dissection. But sometimes when your tumor is very big, and you cannot approach this is, you rather than entering inside the pericle and ligating, isolating individually, this is entire chunk to ligate as a bulk. Okay. So at this part, you have some vessels. Usually, I use blunt scissor, where you remove the region. Sometimes you have to use QSA, sometimes you have to do some little hepatectomy here, and you enter in this region. First thing is that you ligate, you look the entire right pericle. this is the part you must get the access of this first. Once you get it, you put the right angle from here. So your right angle, the right angle that
आवाज
is
का बंद केलायस तू
below.
आवाज का बंद केला
My voice is not coming. Hello, my voice is not coming. Hello.
It's coming. It's coming.
No. I have paused the video. I have paused the video. I'm just explaining this video. Now, this is right anterior pedicle and this is right posterior pedicle. So when you have to do selectively, right anterior section, that is the time you just you ligate here and proceed with right anterior transection. And if you ligate this particular part, is right posterior one. Either you can also write hepatectomy. In that case, if you go for Gastroenterology, then you don't have to ligate the bile duct, artery, or portal vein separately. But this chunk is very kind of thick, so you have to make sure that you close it very well. Some people use this is the left-sided one.
काय माझ्यातला आता बदल करू नकोस
तुझाच आवाज आहे
Difficulty. I hope you are seeing this video. My voice is audible.
Hello.
Am I audible?
Yes, please.
I suggest please, I'm getting some background noises. If anybody is having, can you please mute your mics? So this is the glycogen approach. Okay, I'll just run to the slide. I'll go to the next slide, and then you proceed with transection. The transection technique will come. Okay, so now the total vascular exclusion. Now this is about inflow control. Total vascular exclusion. I'm sorry. Manmohan, a lot of things are coming in front of my screen, so I'm getting disturbed. Exactly coming on my in the center. Can you please remove that one? Okay, so sorry for the disturbance. Total vascular exclusion now, as you can see here, the first image, put the suprahepatic clamp, infrahepatic clamp, and the clamp just now I showed it. So now once you do it, in this case, generally this method you use when you do hepatic resection for trauma, where patient is bleeding, hemodynamically unstable, you don't have much time for separation. So make sure that, suppose just take a hypothetical example, you got grade 4 liver injury with the dissection running through this posterior part of the liver. Right here is bleeding, patient is hypertensive, 60 by non-recordable, lot of blood, hemoperitoneum. You open the abdomen. Now you visibly see big laceration running through the liver, going right up to the IVC. You don't know what to do. Patient is crashing. That is time. First, you put the clamp, right inflow here, intrahepatic, suprahepatic. Wait for a moment. You have now 10 to 12 minutes. Then make sure that ask anesthesia to fill up, give blood transfusion, give fluids, blood pressure, your inotropes and everything. When blood pressure picks up, stabilize it. That is the time you quickly finish your resection. This method really helps in trauma surgeries or whenever you think you are doing hepatectomy, major vessel gets damaged, bleeding, you don't know what to do. So, but whenever you apply total vascular exclusion, so you are clogged. And other they are selective and super selective. Selective total vascular exclusion. Now I tell you, again, I either you do right hepatectomy or left hepatectomy. So once you start doing right hepatectomy, you are isolated your right portal vein, right hepatic artery, and you mobilize the liver first. You isolate the right hepatic vein. Then you proceed with the hilum. You loop right portal vein, right hepatic artery. And now when you have to do as less blood loss as possible. That is the time after my philosophy is that after 25% of the section, when I make sure that okay, I'm ready for irreversible step, that is the time I like it the right hepatic right pericle is ligated. That is it, and you use one Pringle one occlusion on the right hepatic vein. So practically there is no blood flowing in or out from the right side. So it is completely bloodless. And then you use the Pringle maneuver. So whatever remaining left side from the image tributary, it will stop coming. So practically this is very fast, proceeds very smoothly. Same thing goes for the left side. Um, Speaking slides, don't disturb. Okay. Post-operative failure, it depends upon the future remnant
Negative.
We had a big technical disruption. Can you hear me? Everybody, can you hear me?
Yes, you are audible.
Okay, so there was big technical disruption, some problem with IT department, and again. Should not have happened. So here was like parenchyma preserving technique again. I tried to because others are also waiting for the presentation. So decreases parenchyma preserving technique. Make sure that every goal liver resection. The only one goal is that your future liver remnant volume should be good, adequate, so that you shouldn't suffer any post-operative liver insufficiency. There is the worst nightmare any liver surgeon have. So how you do your technique and everything. Before surgery, if your remnant is less, then I told like what are the parameters. What are the techniques which you can increase the liver remnant volume? And what are the ways you can avoid? Make sure that your transaction is as less blood loss as possible. So, there are certain like protogen emulsion technique. As you can see, this is yellow. It is when colorectal mets. This yellow thing you can say mets in the right side. If you do right hepatectomy here, but your left volume is less, in that case you can do entire right emulation. Here, if your remnant is here on this second image, you can see my cursor where you have tumors on the right side. Also, one is segment 4. That time you can do right side emulation plus selective segment 4 emulation, and then lateral segment A will segment 4A will have a problem. And so in the case, such is the case in other scenarios. I also mentioned about ALPPS when you cannot do when price segmentomy liver segment is less than 20%. That is a time you cut the liver, you cut it open, but do not remove it. You ligate the inflow
9967.
ligate or temper the outflow vehicle. That is the time you close the abdomen. There's polythene. You wrap the cut liver in that and close the abdomen, and again come back after 2 weeks where there will be adequate regeneration of the future liver. It's called LPPS. The indication when bilobar metastasis, colorectal leomas, perianal intrahepatic cholangiocarcinoma, and when evaluation there is time LPPS help. But in the
मेरे को भूखा भेज दिया वापस यार भूखा बंगाली चावल डाल के ना मैं उतार दूंगा बाद में
Mr. Abdul Azim,
मैं कर लूंगा
can you please
Please mute everyone.
mute your thing? LPPS.
चावल डाल के दो आप लोग चले जाओ मैं
Hello, who is Dr. Abdul Aziz Khan? I'll mute it. Ask. It's a lot of disturbance. So please take the photography. These are the studies how LPPS helps. since when I lost my audio, just now. So now this technique, diet technique is used. Sometimes what happens, liver is cirrhotic, liver is kind of dirty. You're not able to visibly appreciate the demarcation. Usually, very straightforward thing is the right or left. You like it the right or left pedicle, you get clear cut demarcation line. But when liver is mildly cirrhotic, there is a time you use the diet technique where it gives the clear demarcation. There are same measures. Here you see this right anterior segment. When you inject the dye, right anterior segment, in glycerin pedicle approach, or individually you can dissect the right portal vein and right anterior segment, and when you ligate it, you will get this demarcation of the right anterior when you decide to do right anterior liver resection. But when you see now, when you do right anterior resection, the indication are very less. When you have to, there is no remnant liver, left liver doesn't look functionally well. There is a time you research the right anterior section because the cut margin is very big. If left liver is big, you straight away go for right hepatectomy. My suggestion. So whenever you do, I see in the left side, right side looks big, left side is demarcated. In left hepatectomy, you get clear cut demarcation here and proceed with hepatectomy. The postoperative hemorrhage and bile leak. Now, see, now you wonder like how you do hepatic parenchyma transection. It was like initially when all these instruments were not available. The finger fracture technique is kind of very crude technique, but it is helpful in liver trauma patients where you don't have much time. You have to proceed very fast. So there is time you usually use finger fracture technique, clamp crush technique, or Kelly technique, bipolar dissection, and QSA dissection. Everybody must be about Kelly crush. You crush with the gentle force so that you crush the parenchyma but not the vessel. And I tell you, I always say that when you use Kelly crush technique, your clamp is basically extension. It should be extension of your finger through the Kelly. You should be able to feel all the small vessels. So you shouldn't crush too hard that you will cut because these vessels are already delicate. So your clamping, crushing should be hard enough to crush parenchyma, but soft enough not to damage the vascular biliary structures. And then as I told initially that when you think the vessel is 1 millimeter, buzz it, 2 millimeter, clip it, 3 or more, you ligate and transfix it. Usually we most of the time, 99% time we use Kelly crush technique with simple coagulation and also either ligatio or handheld harmonic. These are the suture materials we use it for ligation of the vessels. Sometimes I create, but most of the time is like 4 or 5 of proline. When this instrument usually used in laparoscopic hepatectomy, but also if you want to use bigger pedicle comes, your clamp is not getting fitted. There is a time you can straight away use this stapler, vascular stapler. Usually this stapler is used in laparoscopic surgeries. This is the QSA. Everybody must have seen the QSA machine. We keep 70 amplitude suction and everything 70, 60, 70, this configuration I keep. So ultrasonic dissector using QSA, cavitron ultrasonic surgical aspirator, there is a long form of that. We can take the screenshot, please read that one and go through every study, try to find out the article and read about it. Like saline coupled bipolar electrode, usually in Korean country, Japanese country. I was studying Taiwan, we were using Kelly crush or QSA. If QSA is not, then we use Kelly crush, but some like in Korea and somewhere they use bipolar with continuous saline trickling. That is also good technique but it is very slowly. It is very slow technique, but it's also meticulous one. If there are 3-4 techniques or surgeon choice which you think comfortable and easy to use. So as for any liver surgery, first we proceed with liver mobilization. You cut the umbilical ligament. You proceed further. You go to the Where is the cursor? Here. You go to the root of the vein. Once you see the root of the vein, make sure that here you should be insinuate your one finger. Okay. So either you do right or left. So this should be the common step. When you are doing right hepatectomy, then you proceed. You cut the right triangular ligament, then you mobilize the liver up. Now this right hepatectomy, slowly mobilize the liver, turn, and rotate the liver. The liver rotation very important. Please do not pull, don't try to extract it. Rotate it. For rotation is that sometimes the left side liver is big, or left side liver is kind of a tongue formation. Sometimes it rolls and it hits the stomach. There is a time you make sure that left side tongue of the liver is nicely rolled, so it's not hitting the stomach, so that you'll not have any problem with mobilization and rolling or rotating the liver. Once you come here, as you proceed, first identify the inferior IVC, proceed through it, see the vessels, ligate them, same technique, isolate them, ligate them, suture them, and you get hepatocaval ligament. Some people call Makuch ligament. It may contain a big vessel, and this is a flattened big vessel. So please do not cut this structure directly. Sometimes it may be 3 or 4 centimeters in length. Do not try to pull your right angle of mixture and come through it. It may be entire thing may be vessel. So make sure that this entire thing you dissect it, loop it, then put Sarinsky and suture it. This picture is shown. Because sometimes, in 10% of the time, that contains the parenchyma of the liver. Choroid lobe is encircling. So that is the worst nightmare of surgeon. When choroid lobe is entirely encircling, that time you have to do choroid hepatectomy. Left side, same. That when you're doing left hepatectomy, you don't have to mobilize the choroid lobe. Just. Now I tell you one thing. When anybody attempted left hepatectomy, transection of left hepatectomy is easier. You don't have to mobilize. But my part is that whenever I do left hepatectomy, I do mobilize the right side, so that I rotate the liver, because the transection line, it comes in the center. That is whether I'm doing right or left, I completely mobilize the right side. And when even if I'm doing left hepatectomy on the right side, I clear the lower part of liver, form this IVC, and then I keep one gauze piece over it, and then I start transection, because once you start transection, when you come near the IVC infravena cava, at the time this gauze piece which you have kept, that will kind of help you, prevent you from going directly in the IVC. So please follow this technique when you do left hepatectomy. And at the root of the choroid lobe, the IVC or left hepatic vein, and there is slight one gap comes from here. You can loop. This is a dangerous technique. Make sure that you identify. Otherwise, just leave it there. You don't have to loop it. You can loop it in the end. But if you can loop it, you have to go in this direction at the root of the upper edge of the choroid lobe and left lobe, where the ductus venous remnant is there, where it ends. Exactly that part where you can gently proceed. Use the blunt right angle dissector. Okay. So, and hanging maneuver you must have. Basically, the first hanging maneuver, the original hanging maneuver is that it was in anterior approach without mobilizing liver. You cut, as you see on the right side of this image, you can see here the central part of the IVC. There are hardly any vessels. When you proceed with the straight with the Kelly straight up, you come between the right hepatic vein and middle hepatic vein. Then you pass infiltrating tube and you lift the liver up. This is anterior approach without mobilizing it. But nowadays we do modified way. I mobilize the right lobe and then I pass it the infiltrating same way, but after mobilizing the liver. So when you are in halfway transection through, then you pull the right tube or feeding tube or whatever thing you are using for hanging maneuver up. So it will give you kind of a blanching effect on the remaining, it will kind of splaying effect on the remaining parenchyma, and it is just, experience your transection. Now, liver resection hepatoblastoma. As you can see, I was mentioning before that this patient basically with the tumor. Now you see the tumor size is only 5 centimeters, but still it was kind of inoperable because RHV is involved, MHV is also involved, and it was brushing with the left hepatic vein. Now, this patient was asked to undergo liver transplantation in 2 centers when he came here. Now, you cannot, preserve this remaining liver, though it appears normal because the right hepatic vein is involved, the middle hepatic vein is involved. So you have to cut you have to cut the right extended hepatic tummy. But now, problem wasn't just this, the tumor was affecting the left hepatic vein. So in this case, they already had identified donor, but we thought the remaining remnant liver of the CT scan volumetry was 23%. Patient metabolically was good, not much burden. His albumin level was good, synthetic function was good, INR, everything was normal. He was child A category, so we could take risk. So we did extended heparectomy. Now you can see here there was this is demarcation of the right side, but as we went on dissecting on the upper segment 4B, I call it segment in eastern side. This is segment 4B. So 4B, we diverted our plane on the left side. We identified the left hepatic vein. Then we went flush with the left hepatic vein. We gently scraped off the tumor from left hepatic vein. This was after, of course, after four cycles of chemotherapy, and then we could remove the specimen. Patient, of course, developed extended small flower size syndrome. Albumin went down to 2.2, developed some ascites. INR went a little high, but after 7 or 8 days, patient started recovering because after 48 hours, liver regeneration starts. So in 7 days time, it was enough liver regenerating enough to start supporting the metabolic lost functions. The patient did well, so we avoided liver transplantation in this patient. Now this is left lateral hepatectomy. So this is primary vascular neoplasm of the liver angiosarcoma epithelial or extended introduced period. There is no, this was hepatic angiosarcoma. There is no current consensus like how you should manage. It depends upon the extent of disease. Usually involves combination of chemotherapy, neoadjuvant or adjuvant. In this patient, these were 4 years child diagnosed with hepatic angiosarcoma after undergoing 4 cycles of chemotherapy. When tumor regressed sufficiently, curative resection was planned. As shown in the image, then left heparectomy was done with partial section of segment 5. Intraoperative ultrasound with standard resection and confirmed no residual disease. Surgical steps, as I mentioned, this was the steps. Blood loss in this particular patient a little more. We try to keep less than 100. It was probably 200. Now, this is very peculiar case. Now, this is liver resection for benign indication. Now, this patient, he didn't have any liver tumor, anything. Then why we are doing liver resection in this patient? This was diaphragmatic hernia patient at the age of 14 years, recurrent diaphragmatic hernia. He was operated at the age of 14 months somewhere else. So the diaphragmatic hernia recurred. So there was recurrence of diaphragmatic hernia. But what happened there? Entire right lobe, is migrated inside the right chest cavity. Patient came with a lot of upper respiratory tract symptoms with cough and inability to sleep in supine position. So when we saw that entire right lobe was inside the liver, first of all, a pediatric surgeon tried reducing it, but reduction was impossible because there was no space in the right subcostal space without compromising the IBC. It was getting kinked. Patient was becoming hypertensive. So we stopped the surgery initially. So a pediatric surgeon stopped the surgery. Then we planned the surgery. Patient was again taken to the ward. I planned the surgery that there were 3 ways. Either we should do formal right heparectomy, which is too invasive for benign indication. So in this patient, what we did is that, as you see here, the CT scan, where entire this is the right pleural cavity. Okay? This is the right thoracic cavity. So entire right lobe was inside. First, what we did was that we mobilized the liver, remove all the attachment from the pleura, from the lungs, from the cardiac. There were big tough adhesions with the right pericardium. We also planned to remove the pericardium if it was a dense adhesion, but we could separate it without affecting pericardium. So once liver was completely mobilized, then we planned partial resection parts in segment 7 and 8. Once it was this transaction was done is a Kelly crush. And as you can see, this particular image, the diaphragm was restored using reinforced procedure. Patient did well. is our surgical team, and this is my mentor, Professor Chan, from Taiwan. Surgery complications do happen, but how boldly you face them and how effectively rectified them that defines your surgical training and skills. Okay. Thank you so much, Professor. Thank you so much, entire audience. Yeah. Anybody प्रश्न आता का नंतर?
प्रश्न नाही
करू मी?
Yes.
Good afternoon, all. I'm Dr. Aditya Kulkarni, consultant pediatric gastroenterology, pathology, and nutrition from SRCC Children's Hospital Management, Manika, Mumbai. The topic for today's masterclass that has been allotted to me is drug-induced liver injury in pediatric patients. I hope I'm audible to all. So we start with the introduction, definition, and classification. Move on to pathophysiology in brief. We'll discuss a few causative agents, clinically important drugs that are likely to cause DILI or drug-induced liver injury. We'll see what are the diagnostic methods and how to assess the severity. What are the clinical features, management, and some takeaways. So, drug-induced liver injury or DILI refers to liver damage which is caused by medication, herbal product, dietary supplement, or other xenobiotics. Here, the word xenobiotic means any subject, any molecule that is foreign to a human body. It can belong to the pharmacological class or it can belong to a herbal class. But it is something that has been not produced in the human body, but our liver has to process it by itself. The DILI may present as isolated rise in liver enzymes, hepatitis, cholestasis, or rarely even acute liver failure. The reason it matters in children is because DILI is an important cause of acute hepatitis and pediatric acute liver failure over the entire population in the world. In one of the important study group, which was conducted by PALF study group, which stands for Pediatric Acute Liver Failure Study Group, noted that nearly 14% of the cases were associated with paracetamol-associated liver failure. Now, what is important here is that DILI, there is no single test to diagnose a drug-induced liver injury. Ultimately, it's going to be a diagnosis of exclusion. We will have to conduct an extensive investigation, rule out important likely etiologies and mimics of the chronic liver diseases, and then probably say that this is still going to be a probable. The word probable here is going to be very important because in order to prove the causality, you need a lot of factors which will be dealing in the subsequent slides. So broadly speaking, there are two types of DILI. We'll go again in detail. One is called as intrinsic DILI, which is basically a predictable and a dose-dependent adverse drug reaction. The idiosyncratic DILI is something which is unpredictable, and it is important from the point of view of the pharmacovigilance, because most of the post-marketing drug withdrawals that happen from the market are happening because of idiosyncratic DILI. So how common is the DILI in children? It's not too common, but it's worth noting because we have to exclude the mimics which present in the similar manner. It can progress easily from jaundice to coagulopathy to acute liver failure in a matter of few hours. Like I mentioned earlier, the PALF study group noticed that 14% of the cases, this is basically related to a Western data, but they had found that 14% of those cases were in the pediatric age group, the ALF was caused by acetaminophen or paracetamol. 5% of those belonged to other drugs, and it resulted in 1.89% of the hospitalized pediatric hepatic cases in one of the Romanian studies. So it is difficult to measure because for judging the incidence of any condition in medicine, we require a common denominator. We require something that needs to be compared in a homogeneous way. Here, the data is very sparse and is heterogeneous. The denominator in most of these studies include adverse drug reactions for all the medicines, children who are receiving high-risk drugs, acute liver failure cohorts, or hospitalized liver diseases. So incidence figure is this no one figure that we should attribute it's important to, but what matters is that the risk rises significantly in patients receiving certain medicine groups. And one of the most important thing from our point of view in Indian scenario with prevalence of tuberculosis is anti-tubercular therapy. The children who are on chronic long-term anti-epileptic polytherapies, lot of children with malnutrition, oncologic chemotherapy, herbal supplements, and unsupervised medications. What is important here is that we cannot label a child with a blanket DILI in that mindset, because it can present in the form of hepatitis after a drug exposure with a long lag period in between. So we need to be very sure about exclusion of other causes. So this was one of the important in a Chinese cohort study, which included nearly 26,000 cases, which had some sort of drug-related liver injury, out of which they found that 460 cases were identified with high confidence DILI as per ASL criteria. This is European Association of Study of Liver Diseases. Will go what are the criteria in the future slides. The children in this study were found to have experienced adverse drug reactions nearly 4 times as compared to adult. And this was mostly related to the lagging maturation of the metabolism and the organs in the pediatric population. As we can see, the acute lymphoblastic leukemia chemotherapy in this particular age group, in this particular cohort, resulted in nearly 78% of the DILIs. Anti-tubercular therapy was responsible for around 15%. While the general pediatric DILI, due to other medicines, resulted in around 10%. 29% of the children included in this data were having acetaminophen, including ALF of unknown etiologies. So looking at the epidemiological patterns, the infants and toddlers have higher concerns with the dosing error. There are various dosing forms available. Some are in the form of tablets, some in the suspension, with different formation, different formulations, and different concentration of the same drug in different forms. So higher concerns with the dosing errors are mostly common with the younger children, infants and toddlers. So we see drugs like valproate getting over-administered pretty frequently. As in association, if there is malnutrition, if there is mitochondrial disease or severe metabolic disease, we have found that the DILI happens very commonly here. So the practical point here is, since the inborn errors of metabolism are very common in infants, we also need to look for those before calling it a drug-induced liver injury. The age also influences the nutritional reserve, the capacity of the liver to metabolize certain xenobiotics, which we call it as hepatic reserve. Recognition of symptoms is not that easy in this population. There is likelihood of intentional overdose when we are talking about adolescents, because we are then talking about psychological illnesses, suicidal intent, and all those things. Plus, there can be a background risk of genetic liver disease as well. In the school-going age group, common clinical scenarios include children on epilepsy drugs, tuberculosis, or recurrent infections. And worth noting here is that we need to exclude viral, autoimmune, and Wilson's disease, because this is the age group where they start showing their main clinical features. Like I said, adolescents, intentional overdose, and even supplements with some sort of a gym going supplements. They could be fat burners, they could be protein supplements which have been spiked up with anabolic steroids. A lot of sources are there. So we need to ask very carefully about the weight loss agents, about the overdose, and the gym products. So what are the risk factors for pediatric DILI? We can broadly divide them into 3 subgroups. One is host factor, one is environmental factors, and drug-related factors. In between the host factors, younger age, less than 2 years, carry highest risk. Female genders has been found to be more commonly involved, although that is a correlation, not a causation. Malnutrition resulted in nearly 70% increased chance and propensity of DILI cases in the Chinese cohort. Similarly, if there are certain genetic polymorphisms, in the cytochrome system or in some of the important enzymes which are involved in the metabolism of the drugs, they can predispose certain individuals. The drug-related factors here include polypharmacy, very common in, say, for example, oncological wards in ICU setups, dose and duration of the therapy. So many drug-drug interactions, we keep on adding and piling up one drug over other without actually caring and without actually looking at which drug is going to influence the metabolism of other drug and thus lead to increased side effects. Microsomal enzyme induces the pattern and the parental versus oral route of administration and re-challenge with the same agent. Some of the environmental factors consist of malnutrition status plus access to monitoring. This is especially important in anti-tubercular therapy, where we need to de-challenge and when subsequently reintroducing the same tuberculosis drugs, the patient needs to have access on a weekly basis, sometimes even on a daily basis, to the laboratories and to qualified doctors, to specialists, to introduce the drugs in the safe conditions. Seasonal illness pattern and socioeconomic disparities consist of other factors. So the insight here is that malnutrition causes nearly 2 times as frequent pediatric DILI as compared to well-nourished counterparts. The baseline LFT should be obtained before initiating hepatotoxic drugs in malnourished children. That is something that we can make a mental note of before proceeding further, because it's always better to have a baseline that we have to compare it to a future trend, because a trend is more important than an absolute value. Closer monitoring is also required and warranted for less than 2 years of age, particularly on high-risk drugs such as anti-tuberculosis therapy or antiepileptics. So the European Association of Study for Liver Diseases, EASL, has come up with the biochemical criteria for suspected DILI. They formed a network called the DILI network and found out 3 patterns of the liver injury and correlated that with the liver enzyme. So if the ALT or SGPT is more than or equal to 5 times the upper limit of normal for that age, we call it a hepatocellular injury. If the alkaline phosphatase is more than 2 times the upper limit of normal, especially with raised GGT, it is cholestatic injury. Here the important note is that alkaline phosphatase is an enzyme that has been influenced by a lot of other factors, including bone growth in the pediatric population. So it's not specific for the cholestatic injury. In that case, we can include gamma glutamyl transferase GGT for the same reason. While if the ALT is more than 3 times the upper limit of normal with a total bilirubin which is more than twice the upper limit, we call it a mixed injury, or which is a clinically significant. Now, like I said, the common mimics such as viral hepatitis, autoimmune hepatitis, Wilson's disease, biliary obstruction, and sepsis, and some of the genetic liver diseases also need to be excluded before calling it a DILI, even though the reports are fitting these biochemical thresholds. The intrinsic versus idiosyncratic model, the intrinsic basically means the side effects, the adverse reactions are going to be a bit predictable. They are going to be dose dependent, and the occurrence affects most of the exposed individual at a sufficient dose. The prototype here is acetaminophen or paracetamol poisoning, while idiosyncratic DILI are dangerous in the sense that we are not able to fully expect them. They can happen at usual doses, they are unpredictable, and regardless of the dose or duration, small population of the patients will get these sorts of DILI. The latency can be variable as well. Thus, the causation attribution factor of the causation is going to be difficult. And subtypes include immune-mediated and metabolic DILI. Now, R value is something EASL came up with. R value is actually the ratio of number of times SGPT elevation divided by number of times alkaline phosphate has been elevation. So ALT divided by ALT upper limit of normal. The whole thing is divided by alkaline phosphatase divided by its upper normal limit. So if this R value is found to be more than 5, it is a hepatocellular DILI. Again, like we mentioned, most predominant most predominant class is the hepatocellular, and the typical agents include isoniazide, pyrazinamide, valproate, or even paracetamol. These carry the highest risk for acute liver failure. The cholestatic one will be the one where alkaline phosphatase elevation predominates, and they will present in the form of itching, pruritus, jaundice. They can persist for a very long time, and if it is going on for more than 6 months or so, they can also lead to something called as vanishing bile duct syndrome. The typical agents included here are amoxiclav, macrolides, and cephalosporins. While the mixed R value is between 2 to 5, the mixed type of DILI will be seen more common with aromatic antiepileptics such as carbamazepine or phenytoin. In the same Chinese nationwide cohort study, which was conducted in 2024, they found out that 63% of the pediatric DILI was basically hepatocellular. They also suggested to use GGT to support the cholestasis. The other obstructive enzyme which we can use here is 5' nucleotidase, but it's not routinely done. So GGT is a valuable alternative to alkaline phosphatase. And the pattern classification determines RUCAM scoring approach, which we'll see in the future slide. So the RUCAM scoring system is a causality association model. This is called as Russell UCLF causality assessment. This is most widely used structural causality tool. So this is not something which is going to define DILI or confirm the DILI. But when there are multiple drugs involved, which are likely to be hepatotoxic, when there are likely confounding factors such as sepsis ongoing, when there is infection which has happened in the recent past, if the patient was in ICU setup for some time, then there is quite a bit of discordance, and we cannot attribute the one drug to be causing the entire DILI. So this model includes 6 to 7 domains, which is like a temporal relationship, risk factors, course after D-challenge, concomitant drugs, exclusion of other causes, and re-challenge. Each of these domains can be graded from -3, -2 to say +3. And this model can be individually applied to all of the drugs involved. Based on the final score that we get, the score interpretation, as we see on the right side of the table, we can say that it's less likely to be a DILI-related liver injury if the score comes less than 0. 1 to 2 is unlikely, 3 to 5 is possible, 6 to 8 is highly probable, and more than 9 is likely to be highly probable. So if you see that there is no parameter here which says more than say 10 is confirmatory, because that is not a real life practical scenario. The real life practical scenario are going to be messy with a lot of confounding factors, a lot of overlapping factors having a role and playing the role in simultaneously. The other thing is that this was a scoring system important from pharmacovigilance point of view, from insurance point of view, from actually applying and seeing the diagnostic anatomy of DILI. But it was first introduced and studied in adult population. So some of these domains also include factors such as age more than 55, alcohol intake, which are obviously not applicable in the pediatric population. Then we go on to see what is the severity grading and what is Hayes law. Now, Hayes law is something that a German hepatologist, Hermann Zimmermann, proposed. He said that if a patient is showing the LFT characteristics where ALT or AST is more than 3 times the upper limit of normal, plus the bilirubin has to be more than 2 times the upper limit of normal, plus there is no significant cholestatic enzyme elevation, and there is no alternative explanation for it. According to him, this kind of cohort of the patients fit more decently with a worse prognosis. So clinical severity grading, Hayes law, again, it's very important from the historical point of view, but practically speaking, we can divide the patients to be having mild, moderate, and severe DILI on the basis of few other factors also. One of which is mild, will be having only enzyme elevations, but the bilirubin and INR will be normal. And the action required will be just to review. It doesn't require immediate cessation, doesn't require doing over-the-top things right away. Moderate severity of the DILI will have jaundice, but it will start showing some sort of a synthetic dysfunction. We'll start seeing worsening enzymes, we'll start seeing bilirubin elevation. So the action here is stopping the suspected drug and closely following up the LFTs. Severe DILI will have complete synthetic dysfunction as defined by international normalized ratio INR more than 1.5, encephalopathy, hypoglycemia, AKI, and fatal sort of systemic instability. And at that point, you're looking at urgent liver transplant discussion. So the red flags for the severe DILI are encephalopathy, rapidly rising bilirubin, and INR. This is a very important test, which is single-handedly going to tell you how the liver is performing from the reserve point of view. Now, moving on to the pathophysiology. So the liver manages to metabolize these xenobiotics in 3 phases. Phase 1 will be typically handled by cytochrome P450 system of enzymes. Phase 2 is conjugation, and phase 3 is transport. Phase 1, nearly 60% of the drugs that cause DILI are metabolized by cytochromes, and it's a huge family with a subgroup, subfamilies, subgenetic polymorphisms in all of these cytochromes. So CYP2E1, for example, is the one which is associated with acetaminophen, which is associated with paracetamol overdose, because that is the cytochrome that forms NAPQI, which is the toxic metabolite for paracetamol. Now, phase 2 or conjugation is the actual enzymatic processing, and the enzymes which liver uses, the processes are usually glucuronidation, sulfation, acetylation. This acetylation will play some part in the discussion of INH in the future. Then glutathione, and the depletion will increase the toxicity risk. Now, some of the drugs, they also impact the export pumps, like bile salt export pumps, organic anion transporters, and canalicular or sinusoidal proteins. The inhibition of these transport proteins will lead to a lot of elevation of direct bilirubin, and cholestasis will happen. So the important note here is this cytochrome P450 family of the proteins is present in significantly lower quantity in the neonates, and it takes around 8 to 10 years of the life to reach an adult level. This maturation process leads to increased propensity of the infants, because their liver will be more vulnerable. The NAT2 enzyme that we mentioned is isoniazid acetylation, and it also increases independently the risk for isoniazid toxicity in the children. The other enzyme important in this discussion is going to be thiopurine methyltransferase, which impacts which way the metabolism of 6-methylpurine or 6-thioguanine, the important drugs that we use in the chemotherapy, is going to be shuttled so that it increases the hepatotoxicity risk, or it increases the myelosuppression. Now, moving on to the intrinsic DILI in short. So under the top panel, we can see that under normal conditions, a therapeutic dose of paracetamol, 90 to 95% will be handled by glucuronidation and sulfation. 5 to 10% will be handled by CYP2E1, that leads to NAPQI formation. And glutathione detoxifies this NAPQI, thus removing the entire hazardous substance from our body. Now, when the paracetamol has gone in a massive dose, such as more than 150 mg per kg, there is huge quantity of NAPQI formation, which depletes the glutathione. And once the stores are exhausted, hepatocellular necrosis occurs. So in the PALS study group, they studied 666 children, out of which, like we mentioned earlier, 14% were pediatric ALF group. But they found that 13% of these children had a single massive dose injection that resulted in ALF, while 13% had chronic subtherapeutic injection or exposure. So the paracetamol toxicity again can happen with a single massive dose. It can also happen with a staggered dose, which is a massive amount but taken over a small period of time over 24 hours. For example, an adolescent having 10 tablets in the morning, then 5 tablets in the afternoon, 4 tablets at night. While chronic supratherapeutic exposure is something that happens over a period of, say, 3-4 days. For example, a parent would administer cough syrup, cold syrups, uh, ibuprofen, and a lot of antipyretics stacked on top of each other that increases the cumulative toxicity. So acetaminophen in that case can cause the toxicity in 4 phases, like we will see in the next slide. The first few hours, first day would typically be asymptomatic. Second day will start with right upper quadrant pain. Peak hepatotoxicity will be established at 72 to 96 hours, and stage 4 will be the recovery phase. Now, idiosyncratic DILI. The classic hallmarks are fever, rash, eosinophilia, lymphadenopathy, and sometimes they are also associated with antibody positivity. So ANA, SMA, this creates a confusion between labeling it as an idiosyncratic DILI and calling it a separate entity called autoimmune hepatitis. So there is another term for this called as drug-induced autoimmune hepatitis, or DIAIH. HLA association also plays part in immune-mediated DILI, and the agents that can be contributing to this kind of a reaction are usually anti-epileptics causing AHS, or anticonvulsant hypersensitivity syndrome, that results in a fever, rash, and internal organ involvement, or a DRESS syndrome, which is drug reaction with eosinophilia and systemic symptoms. In severe cases, for example, with carbamazepine, we've seen that Stevens-Johnson's and even HLH can happen together. The metabolic idiosyncrasy here, which results in formation of the toxic metabolites, can be caused by either mitochondrial dysfunction or genetic polymorphism or BSEP transport inhibition. So here the genetic polymorphism, I'll pay more attention to that. The NAT2 is enzyme which acetylases the isoniazid, and based on the activity of this enzyme, the population can be divided into slow acetylators, normal acetylators, rapid and ultra rapid acetylators. So depending on that, the body's capacity to digest isoniazid, to metabolize it, and to form the toxic metabolites will be varying. Now, valproic acid is the prototype for idiosyncratic DILI. We can see that it can present in the three typical morphologies. One is a hyperammonemia. Second is a hepatocellular, and third is a Reyes syndrome-like disease. The mechanism is that valproate will shift the metabolism from beta oxidation to omega oxidation, and it will lead to formation of toxic metabolites called 4-ene valproate with a secondary carnitine deficiency. So for this prevention, the L-carnitine supplementation is very essential. So like I said, INH, there are two pathways for metabolism. INH is important because, of course, we deal with it in all sorts of antitubercular therapy. It's a backbone, of course. So 50 to 90% of INH will be converted into acetyl INH by N-acetyl transferase 2, which is a NAT2 enzyme, while hydrolysis directly converts into hydrazine and isonicotinic acid. Now, both of these will be metabolized by CYP2E1, and they will be responsible for formation of intermediate. Now, imagine a scenario where this NAT2 activity is very low. So in that case, the acetylation to form the acetyl INH will happen very slowly. So more and more INH will be available to be shuttled to the other side and to undergo hydrolysis and to form a very toxic metabolite of hydrazine. So this is the part where the slow acetylators face more trouble with INH toxicity. Well, if the NAT2 is present in a higher amount, it's going to rapidly convert INH into say monoacetyl hydrazine or isonicotinic acid. And these children are the one who will be actually having subtherapeutic response because their drug is actually going to get cleared from the body very soon. So the reason children are different from adults is we always say that a child is not a small adult. The same physiological mechanisms and the concepts cannot be applied and at a downscaled ratio, at a downscaled size to the children because the enzyme maturation is different. There is a lot of off-label use. Around 50 to 90% prescriptions are off-label, resulting in unpredictable exposure. The nutritional status does impact a lot of DILI risk. Polypharmacy is pretty common, and inherent hepatic reserve is limited. So some of the causative agents we'll go through are one is we'll just go by class. First is antimicrobials, because globally we can say that even though we can't say it's the most leading cause, I would say that it is one of the most common causes of drug-induced liver injury. The some of the American DILI literature do say that antimicrobials lead that chart. So amoxiclav, antitubercular therapy, anti-staph penicillins, all three, the pattern is going to be hepatocellular. Cephalosporin macrolides usually cause cholestatic injury. You can see that this latency is a general guide rule. It's not always going to be rigidly, but we can generally assess and say this is important from the point of view of taking the drug history, because by that, plenty of times what we do is we just ask the patients, what drugs did you take before coming to the hospital? What this table tells you is you may need to go even sometimes up to 8 weeks before the admission, before the patient has presented to you, in order to trace his entire drug history, because of this latency or the lag period. So cephalosporin, biliary pseudolithiasis, it's not a standard, we can call it as a standard DILI, but amoxiclav definitely does cause hepatocellular or anicteric presentation. The antitubercular drug we just mentioned right now, macrolides can lead to self-limiting cholestatic injury, and Septran is also seen in some of the DRESS syndrome cases. Anti-epileptic drugs, like we mentioned, the valproate can present in 3 different kind of manifestations. Highest risk is under 2 years. Secondary carnitine deficiency is pretty common. Phenytoin and carbamazepine produce immune-mediated DILI with DRESS and SGS kind of a presentation. The newer antiepileptics with levetiracetam, they are not completely free, but the DILI is seen very rarely with them. Lamotrigine is also something that has a long lag period of around 6 to 8 weeks before it can present in the form of a hepatocellular injury. So the practical message here is any child on the antiepileptic therapy who develops signs of liver disease, lethargy, pain, maybe jaundice, always consider DILI. We have to take the history about recent dose changes, aromatic compound exposure, polytherapy, and possible even mitochondrial and metabolic diseases. Paracetamol traditionally has been the prototype of the entire label of DILI. So we'll just mention, I'll just mention in short that 150 mg per kg in a single dose or more is a toxic single dose in most of the toxin literatures. Having said that, the other things which impact these are the ways in which the paracetamol is taken. It can be a chronic supratherapeutic dosing, it can be a staggered dosing, but it can be a very late presentation in which the paracetamol level is undetectable. It can still happen. On the right side of this slide, what we can see is a graph that is called as Rumack-Matthews nomogram. On the x-axis is the hours of ingestion after which the patient has presented to you. On the y-axis is the serum acetaminophen level concentration. And there is a line which shows you that this is the pattern of reduction of paracetamol in the serum. If at certain point the paracetamol level of the patient lies above this line, then that is an indication for starting the antidote of paracetamol, which is N-acetylcysteine or NAC. What is important is this is applicable for a single acute ingestion. Even more important is we need to know certainly what was the time of ingestion. So many patients we encounter in the daily practice will be coming with a lot of conflicting history. The timing is never clear. It's always going to be messy. So 4 to 24 hours is the time locked limit during which we can use Rumac-Matthews nomogram for plotting the level. Apart from this, now NSAID is speaking, the ibuprofen is generally safe. Nimesulide is the worst, but it has been banned already. Diclofenac is in between, but it's likely to cause hepatocellular injury. So NSAIDs are also something that we need to monitor very carefully. Aspirin is the prototype, and age-old literature for the Reyes syndrome starts with exposure to aspirin. Antineoplastic agents, acute lymphoblastic leukemia, the liver enzyme elevation is very common during the maintenance therapy of methotrexate plus 6-MP. The other drug is asparaginase that can cause steatosis, while the conditioning regimen, what we use, busulfan, doxorubicin, all these BMT conditioning regimen, they do cause something called as a sinusoidal obstruction syndrome or a hepatic VOD or veno-occlusive disease. This is not a classic DILI because it is more of an endothelial response to the engrafted cells from the BMT. But again, it is something that is very important in the immediate post-BMT period from the point of view of considering a differential when the patient presents with abdominal distension, hepatomegaly, third spacing, and rising or deranged LFTs. The message here is we shouldn't stop reflexively all chemo. Very important to discuss with hepatology because a lot of these transaminases elevation, these are protocol driven. You have to take them as a part and parcel of the protocol of the chemo that you are administering the patient. So not every elevation in the ALT is a drug-induced liver injury. There exists a lot of other differentials, and whether to continue, hold, or find alternatives to these drugs is a joint discussion between the oncology and hepatology. Some of the other common agents are atomoxetine used for ADHD, has the longest lag period of around, say, even 300 to 500 days. Albendazole, deworming tablets and syrups, patients, they give their own children on their own accord without even consulting the doctors. But this Romanian study showed that 35% of their cohort had albendazole induced drug DILI. The green tea extracts, anabolic steroids, and all these are herbal and dietary supplements or HDS because these are more common in adolescents. You have to ask specifically the history for oxidative stress. You have to specifically ask the history for supplemental intake, creatine intake, and immune checkpoint inhibitors are also involved in this class. Now, like we have mentioned a number of times before, DILI is a diagnosis of exclusion. We can follow a structured stepwise framework. Step 1 will be drug history. All prescription histories, OTC and herbal supplements should be sought. Now, it's very difficult to find out the history about this CAM or what we call complementary alternative medicines or CAM-induced DILI because a lot of times they don't have any prescriptions. But then at the most, what we can do is ask the patients, did you receive any cough syrup, any cold syrup, anything to gain weight, anything to kind of increase the immunity? Because immunity boosters, it's that buzzword that is the selling point nowadays for a lot of supplements. So then we can ask them to provide some sort of a photograph of, say, any powders, any syrups, any strip tablets that they had administered. Plenty of times these medicines and these components will not be having a very well disclosed ingredient list, but that is part and parcel of treating such patients. The second step is lab assessment, doing LFT INR with CBC and eosinophils. Third step, calculation of R value to classify whether it is fitting cholestatic or hepatocellular. Step 4 is applying RUCAM staging. Step 5 is exclusion of other causes by doing an extensive but a context-driven investigation to rule out viral hepatitis, AIH, Wilson's disease. Liver biopsy, I'll just talk about it in next slide. It's not always required, but it may be required when the diagnosis still remains uncertain or in a very atypical presentation. So the essential laboratory workup here is SGPT or ALT. Like I've been telling from a long time, upper limit of normal, upper limit. So what is the ULN? Upper limit of normal, which is established by AASLD, American Association of Study for Liver Disease, and also by EASL, include 30 for the AST, 30 for the males and 24 for the females. AST, it is same 30 and 24. Alkaline phosphatase is higher in growing children, so it should be taken with a pinch of salt, maybe even rely on GGT to confirm that this is coming from the biliary source. GGT, the limits are 27 for males, 18 for female, and total bilirubin is 1 for all ages. Extended workup includes viral serologies for commonly included infections such as hepatitis A, E, B, autoimmune markers such as anti-nuclear antibody, SMA, anti-LKM antibodies, ceruloplasmin, and 24-hour urine copper for metabolic workup. And just for completion of the exclusion of the DRESS syndrome, we have to include eosinophils also. The specialized testing would include acetaminophen levels, genetic polymorphism testing in certain cases, TPMT or thiopurine methyltransferase enzyme level is important if you're going to include any thiopurines in the oncological setup in the form of chemo. So liver biopsy is not routinely recommended. When would you still consider? One is when the chronic DILI, you have suspected a drug. You probably took it off, but still the enzyme elevation is going on. This is in the combination with you having already excluded other competing etiologies. Yes, then you should consider. So because it's a diagnosis which is uncertain, atypical features, like I mentioned, DIAIH, the drug-induced autoimmune hepatitis, where you find the autoimmune factors, autoimmune antibodies positivity, but they are associated with drug exposure. When you stop the drug, the antibodies start declining. Or when you consider is exclusion of other causes, when you've done the rest of the workup and still it's not enough. So some of the specific histological findings include acute hepatocellular necrosis like typical ALF picture with paracetamol, cholestasis with amoxicillin, eosinophilic infiltrates, and DRESS syndrome type of thing with immune-mediated DILI of antiepileptics, granulomatous hepatitis with allopurinol, and valproate will lead to steatosis. So differentials are viral hepatitis, where IgM antibody will be positive, autoimmune hepatitis, where female predominance is present, and these antibodies, ANA, SMA, and TLKM, will be positive since way before the patient had exposure to drug, and they will continue to be positive way after the drug has stopped. Interface hepatitis, this is a common histological finding. You will see that in DIAIH also and just primary AIH also. Wilson's disease will be easy to diagnose with ceruloplasmin when the HOT is more than SGPT, alkaline phosphatase, which is very low for the age, with a family history probably. Biliary obstruction will present with pale stools and pruritus. MRCP and GGT will help. A non-alcoholic fatty liver disease or metabolic dysfunction associated with present with dyslipidemia, insulin resistance, and some of the IEMs will require metabolic screens. So clinical presentation, it can be a huge spectrum from asymptomatic elevation to complete ALF. Cholestasis will be with pruritus and pale stools. Acute hepatitis will just be nausea, vomiting, and dark urine with ALT, which is more than 5 times the upper limit of normal. And chronic DILI, which persists for more than 3 months, may show fibrosis, and it is seen with minocycline and nitrofurantoin. So this is all good from the theoretical point of view, but in practice, it's really messy. It's really difficult because a drug is always being combined with a lot of other things. Illness-driven liver injury is going on simultaneously. The patient may have dengue, scrub typhus, leptospirosis, severe sepsis, or shock, which will have a separate shock kind of physiology, lactates, hemodynamics, pressure requirement, hypoxic hepatitis, TPN, and intestinal failure can also impact this thing. So the noting point here is that we can track the systemic illness and perfusion with lactates and AKI and attribute to it more than the drug if possible. Drug-driven or amplified injury is something which happens with antitubercular therapy, valproate, and it's a plausible latency with a recognizable phenotype. De-challenge or removal of the drug is a good signal if it results in improvement of LFT. But so many times, all the factors are chunked together: sepsis, antibiotic, ICU involvement, epilepsy. These are all the combined factors is the real world diagnosis, where you cannot, of course, 100% attribute a liver injury to drugs. At that point, you do not have to chase the label because the treatment of the condition matters more than saying whether drug A caused it or drug B. The general management first principle and the only principle in most of the cases, stop the drug. When you have suspected that something is causing DILI, just stop it completely. You can manage by severity. Like I said, with the mild phenotype, you can continue for some time with weekly monitoring. Moderate requires stopping immediately. Severe DILI with a synthetic dysfunction, stopping the drugs, monitoring INRR, or even involving liver transplant team as soon as possible. The supportive care measures include antiemetics, analgesic, IV hydration, and electrolyte monitoring. So, what are the treatable entities in selected DILI settings? One is N-acetylcysteine. N-acetylcysteine, I'll just deal with it. So N-acetylcysteine is the antidote for paracetamol, like we just saw in the preceding slides. Romac Matthews nomogram plots the serum paracetamol concentration versus time. And this is the standard IV NAC protocol that we use on the left side of the slide, which is a 21-hour standard therapy. First is a 150 mg per kg of a loading dose over 15 to 20 minutes. Second is 50 mg per kg for 4 hours. The third phase starts for 16 hours and it involves 100 mg per kg of NAC. And in selected cases, you can even continue this N-acetylcysteine at the rate, say, 6.25 mg per kg or so. So key management point is start within the 8 hours. Extend the infusion even if the 24 hours are over. If the INR is 2 or the trend is on that worsening manner. So 6.25 mg per kg can be a maintenance dose. The alternative is oral N-acetylcysteine, which was given in the historical times, but not anymore. But when you don't have a confirmed time of ingestion, even any detectable level of paracetamol, AASLD says that yes, you go and give NAC because it is a cheaper drug. It is a drug which is not going to have a lot of side effects, and it is a treatable narrow therapeutic window, which matters more before the patient ends into ALF, where the native liver survival is likely to be very low. Antitubercular therapy, just a few tenets about it. When to stop ATT this is again American Thoracic Society and ICMR have published an entire guideline regarding the antitubercular therapy. When ALT and AST are more than 5 times without symptoms, or when the transaminases are more than 3 times plus associated hepatitis symptoms, or if there is jaundice, bilirubin with coagulopathy, we need to stop INH, rifampicin, and pyrazinamide. In between these 3 drugs, pyrazinamide is the most hepatotoxic, followed by, I would say, INH, and followed by rifampicin. But the worst thing is we never give these drugs separately. It's a combination. So the combination is having even compounded effect when it comes to DILI. Now, while we are waiting, while we have discontinued, If it is urgent TB, we can use some hepatosafe protocols which involve ethambutol, is completely safe, fluoroquinolones, and streptomycin and other aminoglycosides. When to restart, you have to keep monitoring the liver functions on a weekly basis, even sometimes earlier, depending on the general condition. But when the transaminases fall to less than 2 times the upper limit of normal, with the bilirubin which is clearly improving and the INR is stable, you can think about restarting. There are few various guidelines as to how to restart. Most of the guidelines, including the ICMR, says that you can just introduce rifampicin first, wait for 3 to 7 days, add isoniazid. Then wait for 7 to 10 days, add pyrazinamide at the last. During these waiting times, we are not just observing the patient, we are of course tracking the LFTs. If the initial presentation was in the form of severe hepatitis, it's always worth to not reintroduce pyrazinamide completely. We can just omit it and decide to extend the treatment duration. But here comes the role of infection disease expert to decide what regimen to follow next. So when should we escalate to the liver transplant setup? Now, escalation triggers classically defined are when the INR is more than 1.5, there is encephalopathy, hypoglycemia, patient is in acidosis, or AKI is imminent. Don't wait for long, involve and talk to the liver transplant center as early as possible. The ICU priorities include neurological assessment and measures to reduce the intracranial pressure, managing dyselectrolytemia, cerebral edema, and lot of prognostic markers, systems, and literature exist, but we don't have that much of time. We don't have to wait for all these parameters to fit in a particular neat diagram and a neat scoring system in order to involve the liver transplant, because by that time it would be probably too difficult to refer. Often the timing and the transport is a very huge problem in India. So the key question here is not what is the SGPT, what is SGOT, but it is more or less it's whether the synthetic function, which is albumin or PTINR, whether it is worsening or improving. So in addition to that, we can track the INR, glucose, and other labs and decide the overall trajectory. So how to monitor the patient once we have diagnosed and treated the DILI? If the patient is inpatient, if it's admitted, LFT can be done even on a daily basis, twice daily basis, with a neurological check and a fluid intake output charting. But if the patient is on outpatient OPD part, then first couple of weeks, LFT twice a weekly, week 3 to 8. This is just a rough framework, but we can do on a weekly basis for up to 8 weeks. And after month 3, even a monthly is also okay. Now, a lot of this literature involves the word re-challenge, but it's morally and ethically also not correct to re-challenge a certain agent which you have already suspected to cause liver injury. So we avoid the re-challenge unless the drug is absolutely essential, like we just mentioned with the antitubercular therapy. So my key takeaways from this lecture are that think of DILI when the timing is fitting, that it is a diagnosis of exclusion. We have to classify the pattern early because it also changes the treatment. Severity is about the synthetic function and not about just one single value. Stop the culprit when it is safe. Know the treatable scenario. Don't waste time and escalate as early as possible if you feel that the patient is on a downhill course. And re-challenge is rarely casual, and we can just go ahead without it. Thank you so much.
Good evening, everyone. I'm Dr. Manika from Department of Pediatric Surgery. I'll be presenting diagnosis and management of biliary atresia. So jaundice is a common finding in the newborn nursery and in young infants. In a majority of cases, this hyperbilirubinemia is due to elevated unconjugated bilirubin and usually resolves spontaneously with no need of surgical consultation or intervention. But it is important to identify infants who have persistent pathological jaundice beyond 2 weeks of life. And these neonates should be evaluated for biliary obstruction due to biliary atresia. So biliary atresia is defined as complete obliteration or discontinuity of hepatic or common bile duct, which occurs due to progressive damage of extrahepatic and intrahepatic bile ducts secondary to inflammation and leads to fibrosis, biliary cirrhosis, and eventual liver failure. Here, normal extrahepatic biliary system is disrupted. It is seen in 1 in 10,000 to 15,000 births. It is predominant in females with a ratio around 1.4 to 1.7. It is more common in Asian population. It is said to be most common surgically treatable cause of cholestasis in newborns and also most common cause of death resulting from liver disease in early childhood in the Western world. So exact etiology is unknown and causes are multifactorial, ranging from theories which say that the cause can be immunological or inflammatory. It can be also due to viral factors or genetic factors. So there is defect in morphogenesis of the biliary tract. And other causes include ischemic inserts during perinatal period, abnormal bile acid metabolism. So during 4th week of gestation, biliary tree develops from hepatic diverticulum of the foregut, which divides into cranial and caudal component. During this time period, recanalization occurs, and in case of failure of recanalization or remodeling, there is defect in ductal plate malformation leading to biliary atresia. So coming to the types, there are 2 types of biliary atresias, fetal or embryonic type, or the perinatal or acquired form, which is more common. So fetal or embryonic form occurs due to anomalous morphogenesis. Here, the bile ducts are discontinuous at the birth. It can be antenatally detected. Here, there is early cholestasis, which appears within first 2 weeks of life. In these cases, since the physiological jaundice precedes cholestatic jaundice, patients do not have any jaundice-free period. In 10 to 20% of these cases, there is associated congenital malformations such as situs inversus, cardiac anomalies, intestinal atresia. Also, there is BASM, which means a biliary atresia associated with asplenia or polysplenia. Other anomalies such as annular pancreas or abnormal hepatic artery and portal venous anatomy is also seen. So postnatal form or the acquired form is seen in neonates aged 2 to 8 weeks. Here there is progressive inflammation and obliteration of extrahepatic bile duct after birth. So bile ducts are patent at birth, but a suspected inflammatory or sclerosing reaction occurs, which is caused by any perinatal insult and results into obstruction of these extrahepatic biliary ducts. So patient will have adequate birth weight, normal stool, and jaundice develops later after the physiological jaundice has subsided. So these patients may have short jaundice-free interval. Symptoms include change in color, skin, urine, and stool after a while. And these postnatal forms are not associated with congenital anomalies. This is a classification given by Japanese Association of Pediatric Surgeons. There are three types of biliary atresia. So type 1 is the atresia where the atresia is at level of distal bile duct. Type 2 where atresia of common hepatic duct occurs, and type 3 is the atresia at level of porta. So type 2 is divided into two types. Type 2A where common hepatic duct is obliterated, but cystic duct and distal bile duct is patent. You can see it here. And type 2B is where cystic duct, common bile duct, and common hepatic duct all are atretic. So type 3 is the most common type. Coming to the clinical presentation, there is persistent jaundice. It develops at age of 2 to 3 weeks after birth, and it is seen in almost all the patients. There is associated pale colored stools, dark urine, steatorrhea because of reduced fat absorption. Abdominal fullness is seen due to enlarged liver, and patient may present with weight loss, lethargy, or irritability due to deficient fat-soluble vitamins. Also, deficiency of vitamin K can lead to easy bruising of skin, nasal bleeding, which is seen in 3% of the patients. In the later stage, features of cirrhosis is seen, and innately detected subhepatic cyst is seen in 5% of the patients. 5%, another 5% present with features of associated anomalies. During examination, we may find a full-term baby with who had manifested normal growth and weight gain during the first few weeks of life. Patient will be icteric. There can be features of anemia, malnutrition, and maldevelopment. So vital signs of dehydration and weight measurement is a must. There can be peripheral edema. In later stages, hepatomegaly, splenomegaly, ascites are seen. Cardiac murmur is can be there in cases of associated cardiac anomalies. Features of upper GI bleeding can be present, and so stool color should also be examined. Now coming to the differential diagnosis. So extrahepatic etiology which mimic biliary atresia include choledochal cyst, spontaneous perforation of bile duct, inspissated bile or mucus plug, or extrinsic compression of bile duct. Intrahepatic etiology include metabolic syndromes, Alagille syndrome, Caroli disease. So it is important to note that intrahepatic causes of neonatal cholestasis should be kept in mind, because these have to be kept separate from the features of biliary atresia. So these features include these causes can be due to infection caused by virus, different bacteria, and toxoplasma. It can include neonatal cholestasis, also caused by metabolic diseases, genetic diseases, and other embryonic forms such as Alagille syndrome and ductal plate malformation. Also, alpha-1 antitrypsin deficiency is one of the causes of neonatal cholestasis, which should be kept in mind. Coming to the evaluation, so no single test can reliably be used to determine the characteristics of biliary atresia. For this reason, a combination of data obtained from a complete clinical assessment, blood test, imaging studies, and pathologic evaluation is often used to arrive at a provisional diagnosis in almost all the cases. However, the final diagnosis is always confirmed at surgical exploration. So, history and physical examination is important. So, in the blood test, CBC has to be done. So, here direct bilirubin more than 2 mg/% or more than 20% of the total bilirubin level can be seen. So total bilirubin may raise up to 6 to 12 milligram. And in LFT, GGT levels and serum aminotransferase level are important. So also high index of suspicion is key to diagnosis. because direct hyperbilirubinemia may present from birth in fetal or embryonic form, and it should be considered in all neonates with persistent direct hyperbilirubinemia. So some investigations should be kept in mind, which are important to rule out other causes of neonatal cholestasis, such as serum lipoprotein X. These are not commonly done, but just one should know what are the other investigations which are important. So it is positive in all patients with biliary atresia, and abscess excludes the biliary atresia. IgM antibody for TOSH is important in because it is one of the causes of neonatal cholestasis. Serum alpha-1 antitrypsin, sweat chloride, because biliary tract involvement is well-recognized complication of cystic fibrosis. Serum bile acid level increase in infant with cholestatic disease, but it is not useful in differentiating biliary atresia from other cholestatic diseases. Coming to the radiological investigation, ultrasonography with color Doppler improves accuracy. It excludes specific anatomical anomalies of extrahepatic biliary system, particularly choledochal cyst. So during ultrasound, fasting at least 4 hours before examination is important. So there are 3-4 features which are seen during USG. First is triangular quad site, which means visualization of a circumscribed focal triangular or tubular shaped echogenic density, just cranial to portal vein bifurcation. So this is the image showing the sonogram, where this is the triangular quad, which is seen particularly in biliary atresia. So second is fibrous portal plate or thickness of the echogenic anterior wall of the right portal vein more than 4 mm on longitudinal scan. So here, this is the area of increased echogenicity, and it lies anterior to the bifurcation of portal vein. So this is the triangle quad sign, which is shown by the arrow. Next is gallbladder contraction, which is examined after 60 to 90 minutes after the patient has fed. So here the volume of gallbladder is determined, and contraction index is calculated by this formula. Here, contraction index less than mean plus standard deviation plus minus standard deviation. The gallbladder is described to be one with biliary atresia. Gallbladder ghost triad. Here, gallbladder length less than 1.9 centimeter, a thin or indistinct gallbladder wall with lack of smooth muscle or complete echogenic mucosal lining, and an irregular or lobular contour is seen. So these are the 2 scan images where irregular or lobulated contour can be seen. So HIDA scan. In HIDA scan, if excretion of radiotracer into bowel is seen, biliary atresia is virtually excluded. However, if radiotracer excretion is absent after 24 hours, biliary atresia is suspected. So technetium-99 HIDA shares some same hepatocyte uptake, transport, and excretion pathway as bilirubin, and it is excreted in its original form without being conjugated or undergoing significant metabolism. So it is a non-invasive test in cases of biliary atresia, and it helps in differentiating from the other causes of neonatal cholestasis. So use of phenobarbital during 3 to 5 days beforehand aims to reduce the false positive results. So the only disadvantage is that reliability of this HIDA scan is poor in cases of very high conjugated bilirubin levels, and so the sensitivity is high. So this is the picture showing the normal HIDA scan. Here you can see that the illuminated portion of the radio tracer is seen in the distal biliary duct. And this is another picture where the patient had biliary atresia. Here, the radio tracer was not seen even after 24 hours. So it was not excreted into the duodenum. Coming to the liver biopsy, it is useful in evaluating neonatal cholestasis. It differentiates between obstructive and hepatocellular causes of cholestasis with 90% sensitivity and specificity for biliary atresia. So bile ductular proliferation is considered diagnostic. So multiple features can be seen in the microscopic image, such as numerous brown-green bile plug, bridging fibrosis, extrahepatic duct dilatation, and giant cell transformation of hepatocyte. MRCP, it shows the anatomy of hepatic duct, common bile duct, left and right hepatic duct with gallbladder and cystic duct. So it helps in diagnosis and differential diagnosis of biliary atresia and neonatal hepatitis. So findings in infant with biliary atresia include incomplete visualization of extrahepatic biliary system and high signal intensity of periportal area. You can see in this image, this is the MRCP, which demonstrate inverted triangular area of high intensity and normal gallbladder, which can be seen here. So distal bile duct were not seen in this case. So this is another picture where this is a MRCP image obtained in neonatal hepatitis, which show all the biliary radicle along with the gallbladder. And this is the second image where biliary atresia does not show any extrahepatic bile duct except for the this rudimentary gallbladder. Coming to the management, so Kasai enterostomy is considered to be gold standard surgical technique. Other surgical intervention that is useful is intraoperative cholangiogram for diagnosis. So the goal is to operate before 60 to 90 days of life. However, it is not contraindicated after 90 days of age. Preoperative management includes broad spectrum antibiotics, daily dosing of vitamin K, given around 3 to 5 days before the surgery. So surgery Kasai procedure is Roux-en-Y hepatic enterostomy, which was introduced in 1957. So here obliterated biliary remnant is excised flush with portal plate and it is drained with Roux-en-Y hepaticojejunostomy. So bile flow is re-established in 80 to 90% cases if performed in early stages. Here you can see how the surgical picture looks like. So fibrotic biliary tract remnant is identified and the patency of the biliary system is assessed. If it is associated with ductal hypoplasia, further surgical intervention is not indicated and the patient is treated on lines of neonatal hepatitis. Coming to the surgical steps, small incision is placed for intraoperative cholangiogram. Left upper quadrant is examined to look for spleen, that is asplenia or polysplenia has to be looked. Liver biliary structures and porta is inspected. So in biliary atresia, liver looks nodular, fibrotic and greenish in color. If there is rudimentary fibrous gallbladder in the gallbladder fossa, and it has clearly no lumen, then the diagnosis of biliary atresia is confirmed and operation proceeds with dissection of the portal plate. However, if the gallbladder is normal, then the fluid of the gallbladder is aspirated. If the fluid is white, then it confirms the diagnosis of biliary atresia and portal plate dissection is carried on. However, if the fluid is dark in color or if there is any doubt, intraoperative cholangiogram is to be done. So intraoperative cholangiography is performed by putting a purse string, this is the gallbladder, putting a purse string suture to prevent contrast leak. Either a angiocath or laparoscopic cholangiogram catheter is placed into the lumen of the gallbladder, and purse string sutures are tied. Hypac or gastrographin is diluted with normal saline in the ratio 1:1. And this is done to assess the patency this is done to assess the patency of the bile duct. Real-time fluoroscopy is used. So this is the picture. You can see how intraoperative cholangiogram was done. Here the dye had come into the duodenum. So this rules out the biliary atresia. In this scenario, wedge liver biopsy is performed and cholangiogram catheter is removed and cholecystostomy, which is here, is closed and operation is concluded. So in case there is biliary atresia, Kasai-Poto-enterostomy is done. So these are the steps of Kasai-Poto-enterostomy. So the dissection is started at hepatoduodenal ligament. So I'll be showing a video of laparoscopic Kasai procedure. So peritoneum, after the ports are placed and gallbladder is inspected, dissection is started anterior to hepatoduodenal ligament. The fibrotic distal bile duct is isolated, divided, and kept in traction. So gallbladder is also resected in continuity with this fibrotic bile duct. One should be always careful with the anomalous hepatic artery anatomy, which can be seen. So after the division of distal bile duct, a traction is kept cephalad so as to identify the porta, which can be seen at the bifurcation of portal vein. So this is considered to be the landmark and it is the end goal of the surgical dissection. So once porta is identified, the portal plate is dissected and excised with the sharp scissors. So this is the rule limb that has been taken. The jejunum is divided 15 to 20 centimeter distal to ligament of wrist, and rule limb of about 40 to 50 centimeter is prepared from the distal jejunum and is brought up to subhepatic area near the porta for anastomosis. Here the anastomosis is being done using 60 vital sutures. So posterior layer suturing was done, keeping in mind not to injure the portal vein. So once the anastomosis is complete, the portal plate area gets covered with the rule limb so that all the bile can flow distally into the rule limb of the anastomosis. At the towards the end, a drain is placed in the subhepatic area. The specimen is removed and wedge liver biopsy is done. So this is a surgical specimen of obliterated extrahepatic bile duct, which shows triangular cone. This is a triangular cone-shaped fibrous ductal remnant of porta hepatis, and this is the atratic gallbladder with fibrous common bile duct. This is the fibrotic common bile duct. So post-operative management include placement of nasogastric tube, IV fluids. Patient is kept nil by mouth for at least 4 to 5 days, depending on the bowel activity. So long-term antibiotic prophylaxis is needed like up to 3 months to avoid the risk of cholangitis. Role of steroid is that it has anti-inflammatory property and it can act as choleretic agent and stimulate bile salt independent bile flow. So prednisolone at the dose of 2 milligram per kg per day can be given twice daily, and it is started on the 7th post-operative day for 4 days, and then switched to oral administration, and then continued every other day, which can be later tapered over 6 weeks. Methylprednisolone blast therapy can be used in immediate post-operative period to establish bile drainage. Ursodeoxycholic acid is also shown to promote bile flow in cholestatic condition, and it can be given in a dosing of 10 to 15 milligram per kg per day in 2 divided doses. It enhances the biliary drainage. Vitamin supplements, vitamin A, D, K can be given. Medium chain triglyceride oil helps in adding extra calories that will help with the child growth. In intrahepatic biliary atresia, role of cholestyramine is to reduce the bilirubin level and itching. Outcomes of Kasai procedure. So out of all patients, about 1/3 of the patient bile flow is inadequate following surgery. That means biliary cirrhosis sets in later in the life and they need liver transplant. But in rest of the 2/3 patients, pigmented stool is either seen immediately or within first 10 to 14 days after surgery, which suggests successful bile flow. And half of this 2/3 patient will continue to drain bile well and will be considered as and is considered as cure. And liver transplantation is not necessary at all. They will have efficient clearance of jaundice and will have normal development. But the other half of this patient, that is 1/3, will slowly develop some jaundice over the course of a year and will need liver transplant. So potoenterostomy act as a bridge to liver transplant. The success of this procedure is related to the age at which the surgery is done, extent of liver damage or cirrhosis at the time of surgery, the number and size of microscopic duct in the scarred tissue, that is a portal plate that can drain bile, and the experience of the surgical team. So age at surgery. Surgery done before 60 days of age is associated with favorable outcomes. So 10-year survival rate is around 68%. Those who are operated before, and it's around 15% those who get operated after 90 days of life. So size of about 150 microns is considered to be optimum for favorable bile drainage. So the portal plate ductal lumen is an important factor here. Outcomes after Kasai procedure. Short-term bile flow is dependent on the age of Kasai, like I explained. So liver transplantation is required in around 80% of the patients, and 3-year survival rate for children who did not have any drainage procedure was less than 10%. These are the post-surgical complications. So early complication include bile leak due to anastomotic dehiscence, prolonged ileus, intestinal obstruction, wound dehiscence, cholangitis. Late complication includes stoppage of bile flow, recurrent cholangitis, portal hypertension, ascites hepatobiliary syndrome, and cirrhosis. So cholangitis is the most common complication in first 2 years of age. It can range from mild to fulminant sepsis. Features seen are fever, vomiting, jaundice, ecolic stool, abdomen pain, and it can be diagnosed with blood culture. And there are 2 causes for these cholangitis. The first is either there can be ascending infection from the gut, or in later half, obstruction to the drainage of do loop can result into cholangitis. The exact cause of this cholangitis is still unknown, although the reflux of intestinal content via this rule limb and portal venous infection, impaired lymphatic drainage of the porta, and bacterial translocation have been proposed. So the incidence is reduced by antibiotic prophylaxis, which is given for long term, and it helps in restoring good liver function. In cases of cholangitis, it is treated with IV fluids, broad spectrum antibiotics, cholinergic agents, and steroids. Many studies have confirmed that true NY uh, of length around 50 to 70 centimeter is better to avoid cholangitis in the future. Portal hypertension is the most serious complication even in jaundice-free survival. And the incidence varies from 30 to 75%. These patients ultimately need a liver transplant. So cholangitis is one of the risk factors. These patients may present with esophageal varices, which need sclerotherapy or banding later on. So variceal bleeding may occur in 20 to 60% of the patient with esophageal varices. They have associated hypersplenism in 16 to 15%, 16 to 35% of the patients, or associated thrombocytopenia is also common. These hypersplenism patient can be dealt with splenectomy, portosystemic shunting, or splenic embolization in later stages. So hepatopulmonary syndrome is uncommon and is associated with chronic liver disease. So the gut-derived vasoactive substances which are not cleared by cirrhotic liver enter into systemic circulation because of the development of pulmonary arteriovenous shunts. There is triad of liver dysfunction, arterial hypoxemia, and intrapulmonary vascular dilatation. Patient may present with dyspnea and cyanosis. This has a mortality rate of 41%. So it can be diagnosed by pulmonary scintigraphy, and it can be reversed, and it is ultimately reversed by liver transplant. Progressive fibrosis and biliary cirrhosis develop in children who do not drain the bile, and liver transplantation is the only option for long-term survival. So post-Kasai survival rate is around 60% at 5 years of age, and the overall survival for more than 20 years was reported as 22%. Survival period is longer in intrahepatic type rather than extrahepatic types. Biliary atresia is a most common indication for liver transplant, and it is initial treatment of choice when detected late, or may be used as salvage procedure for Kasai, for failed Kasai. Consider liver transplant early in patient. Consider liver transplant early in patients who do not achieve clearing of jaundice following Kasai procedure. That means we will have features of failure of initial photoendoscopy with no bile drainage and progressive liver disease. Or they can have episodic or inefficient bile drainage with slow deterioration of liver function and development of growth failure. And the third group of patients will develop one or more complication of chronic liver disease such as cholangitis, portal hypertension that cannot be easily managed. So these are the three groups of patients which will need liver transplant. So one should be the primary indication for liver transplant are the symptoms of end-stage liver disease. So when liver transplant, the diseased liver is replaced by a new donor liver, and so survival rates approaches up to 80% at 1 year and 70% at 5 years. So the take-home message is that Kasai photoenteroscopy should be offered to all except a selected few patients Best initial surgical treatment. It is the best surgical treatment for biliary atresia. And goal is to operate before 60 to 90 days of life. However, it is not contraindicated after 90 days of life. And early diagnosis is the key in cases of biliary atresia. Thank you. So we'll stop our presentation here. Is there any questions? Is there any question that we can take? So, all right, then we'll conclude our masterclass here. So this masterclass is organized every month on third Wednesday with different topics every month.